Hello, and welcome to our annual webinar, Report Back from San Antonio Breast Cancer Symposium, or we call it SABCS 2022. I'm Victoria Goldberg, and as many of you know, I'm a producer and the host of the Our NBC Live podcast. Please share in the chat where you're joining us from today. We really would love to hear where people are coming from. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancer and provides outreach to the general public about signs and symptoms. Because as we know, no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. Once Dr. Blaes finishes the presentation, we'll begin the Q&A discussion. Feel free to comment in the chat. You can also use the chat or the QA section at the bottom of your screen to ask our presenter a question. But please remember that Dr. Blaes is unable to give specific medical advice, so keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. And hopefully, I will add, we will turn this webinar, as we do all the time, into an Our NBC Live podcast episode. So you will be able to listen to it at some point soon as well. So, I'm honored to present our speaker, Dr. Ann Blaes. And Dr. Ann Blaes will introduce herself. Please, Dr. Ann Blaes, I am turning it over to you.
Thanks, Victoria. It's really my pleasure to be here today. As mentioned, my name is Ann Blaes. I'm a medical oncologist and breast cancer specialist at the University of Minnesota. I'm a professor of medicine here and hold the B.J. Kennedy Chair in Oncology. And at the University of Minnesota, I wear a number of hats. I'm the section head of medical oncology and the current division director for our division. And I'm the director of cancer survivorship services and translational research within the Masonic Cancer Center. Nationally, I work with the Alliance for Cancer Clinical Trials with their breast cancer team. And previously have held a position as being the chair of the American Society of Clinical Oncology's Cancer Survivorship Committee. So thank you so much for having me today. It's really a privilege to be here, and I look forward to talking to all of you during the question and answer period. So let me load my slides. And I'm assuming someone will tell me if you can't see them.
Yes, we can.
Perfect. Do you see them now in a regular format?
Yes, I can.
Perfect. Okay.
I'm sure everyone else does too.
So the only thing I would mention as far as disclosures, I was a speaker and a moderator at the meeting itself. I don't have any other disclosures to share. So I'm going to talk a little bit about updates, particularly in the metastatic setting from San Antonio last month. We'll then talk about a few of the abstracts that highlighted things around curative intent breast cancer, and then move on to a few other what I would call important and relevant topics for breast cancer individuals and their families. So I wanted to start out by really just saying, there were some very unique educational sessions at San Antonio this year. There were educational sessions focused on metastatic breast cancer and really thinking about living well after a diagnosis. I was thrilled personally to be a part of this panel with Stephanie Walker and Christine Hodgson, who are both individuals living with metastatic disease and are fierce advocates. If any of you are looking for additional resources, I would tell you definitely take a look or reach out to these individuals. But the focus was on early palliative care, advocacy, and financial toxicity. There was another educational session on cardio-oncology and really thinking about how do we keep all of you, particularly your heart, healthy while treating your breast cancer. And there were multiple sessions on how do we ensure that we're addressing our diverse patient population of all race and ethnicities within the United States, as well as providing equitable care, really ensuring that excellent treatment is available for all patients. Some of this is based on the biology, looking at what are biologic drivers of breast cancer in our diverse patient population, and some were around access to care. And I was really excited to see this at the meeting this year. So I'm going to go through a series of abstracts that I think are important as I think about metastatic breast cancer. So first of all, the question that comes up for many patients that I oftentimes hear is, I have liver metastases. Isn't this scary? And do I need chemotherapy? There was a clinical trial called the Right Choice trial that looked at premenopausal patients with aggressive hormone receptor positive breast cancer. They were treated with ribociclib and endocrine therapy versus chemotherapy. When thinking about this trial itself, this took women, as I was describing, who actually had liver metastases or other visceral metastases, which really just means in the organs themselves. And they were randomized to endocrine treatment with ribociclib or Kisqali compared to a physician's choice of different kinds of chemotherapy. Their goal was to look at progression-free survival as their primary endpoint, and then a variety of other secondary endpoints. Within the study itself, really the conclusion was that ribociclib combination was superior to chemotherapy in aggressive hormone receptor positive breast cancer. And I'll just show you within looking at the progression-free survival, the ribociclib arm is in the blue and the chemotherapy arm in the gold. In the ribociclib arm, there was almost a doubling of progression-free survival. Time to treatment failure was also extended within this patient population from 8 to 18 months. There were, not surprising, fewer toxicities with the ribociclib over chemotherapy arm, really suggesting that even when a patient's presenting with liver metastases, that this is an option for them to use endocrine therapy. And I would argue for a better option using targeted treatment over standard chemotherapy. In metastatic hormone receptor positive breast cancer, currently CDK4/6 inhibitors are the standard treatment for hormone receptor positive metastatic breast cancer in the first line setting. In current practice, many questions arise when someone has progressive disease. What's the best thing to use in the second or third line treatment? And sequential endocrine monotherapy or combinations of treatment are oftentimes used. Although there's actually very limited data to guide treatment decisions following clinical progression on CDK4/6 inhibitors. So what do we do after someone is on a CDK4/6 inhibitor? What are the best treatment choices? How should we be thinking about this? At ASCO this past summer, the MAINTAIN trial was presented looking at patients who had progression on a CDK4/6 inhibitor and randomized them to ribociclib with a change in endocrine therapy versus just endocrine therapy. You can see there are modest improvements from 2.5 months to 5.5 months in using the ribociclib with endocrine therapy compared to just endocrine therapy alone, really suggesting that ribociclib with endocrine therapy beyond progression on a prior CDK4/6 inhibitor may be beneficial. At San Antonio this year, another trial was presented asking a very similar question called the PACE study. They took patients with metastatic disease that were on CDK4/6 inhibitors with endocrine treatment and randomized them to fulvestrant with palbociclib, or fulvestrant with palbociclib and a type of immunotherapy called avelumab. Even if you're not used to looking at all of these graphs, what you can see is, first of all, the blue and red lines are not different at all. The green line might be slightly differently, suggesting that perhaps the avelumab, which is a type of immunotherapy, may have some effect on this patient population. But really asking the question, is continuing the palbociclib or continuing that CDK4/6 inhibitor in conjunction with fulvestrant does not improve outcomes. So I would argue that from the PACE trial and the MAINTAIN study, combining palbociclib with fulvestrant beyond progression did not improve overall outcomes compared with using fulvestrant alone. As mentioned from the MAINTAIN study, we may get some benefit from switching or using ribociclib, but certainly not palbo in this setting. So what about oral SERDs? When I see patients in the clinic, many of them will tell me, okay, well, tell me what's next. What kind of drugs are available? What kinds of therapies are coming out in the pipeline? So when I think about blocking estrogen, and I'm not sure if you can see the pointer or not, but in the middle is what I think about with tamoxifen. Tamoxifen actually goes in, it blocks the estrogen receptor, and it prevents sort of further downstream target growth. Aromatase inhibitors, on the other hand, actually block estrogen production through this enzyme called aromatase. What oral SERDs for, these actually stand for estrogen receptor degradators, really meaning that when estrogen stimulates the estrogen receptor, these receptors are broken down and further downstream regulation does not happen. Fulvestrant works in this pathway. Elacestrant is an oral SERD that was presented at San Antonio, and I'm going to share some of these results. So the oral SERDs were tested in 2 different trials that were presented at San Antonio as monotherapy in the second and third line setting. The first was in a clinical trial called the Emerald study, and they used elacestrant. In this trial, elacestrant was compared to an aromatase inhibitor or fulvestrant, and there were overall very minor improvements in progression-free survival. The response actually was doubled in those who had an ESR1 mutation. The Serena study looked at a different oral SERD called camizestrant, and they compared this to switching patients to fulvestrant. They assessed this at 2 different dose ranges, and were able to demonstrate improvement in progression-free survival. This was actually doubled to over 7 months in those with an ESR1 mutation, really suggesting that the oral SERDs may be an option in the future. And I would argue, particularly for those with an ESR1 mutation. And for any of you that are listening to this podcast and presentation, right now, not all of you may know whether or not you have an ESR1 mutation. And I'll come back and talk about this at the end. But these are things as oncologists, we oftentimes are asking, first of all, what are other treatment options for our patients? And secondly, who's going to respond best to it? And that's how I would think about the ESR1 mutation. We're learning more about it. And these may be a potential drug option in the future, particularly for this subset of individuals. So what do we do after progression on a CDK4/6 inhibitor? Well, SERD monotherapy with elacestrant or camizestrant shows clinical activity in the second and third line setting. It's really too early for us to say whether patients live longer on these medications. And as I mentioned, who may benefit the most from these drugs, particularly those with an ESR1 mutation, or for those who've actually been on their CDK4/6 inhibitor for over 12 months, may have the greatest benefit from SERD monotherapy. So when I've tried to put this all together, if there's slight progression when somebody's been on a CDK4/6 inhibitor, personally, I would try to switch them to ribociclib with endocrine therapy based on that MAINTAIN study. If they have an ESR mutation, as I just mentioned, the oral SERDs are a good treatment option. Without any of these mutations, everolimus or exemestane may be reasonable. And for some individuals, they have different targeted mutations, such as a BRCA mutation, where PARP inhibitors are a treatment choice, or with a PIK3CA mutation, where Piqray or alpelisib is also a treatment option. So what was updated at San Antonio looking at antibody-drug conjugates? Many of you know that antibody-drug conjugates, these are a class of drugs that use an antibody to guide the delivery of cytotoxic drugs. And the cytotoxic drug is essentially attached to that through a linker. that then is engulfed into the cell, providing direct chemotherapy to the cancer cell as opposed to potentially everywhere in the body. The two most common antibody-drug conjugates are used in HER2-positive breast cancer called Kadcyla and HER2. These are two different compounds. They both use the monoclonal antibody trastuzumab. They have different linkers and then different cytotoxic chemotherapy drugs attached to them. At ESMO in 2021, this was the first randomized phase 3 study looking at trastuzumab deruxtecan or Enhertu. Within this open label trial, they looked at metastatic HER2-positive breast cancer. These patients had all been previously treated with a taxane and trastuzumab, and they were randomized to trastuzumab deruxtecan versus TDM1 or Kadcyla. Their primary endpoint was progression-free survival with a secondary endpoint of overall survival. And what was previously presented at ESMO was really that using trastuzumab deruxtecan showed a median progression-free survival improvement from 34% at 12 months to a near doubling of 75% at 12 months. At the San Antonio Breast Cancer Symposium last month, Hurvitz and colleagues really demonstrated updated data. The progression-free survival was 4 times longer for trastuzumab deruxtecan compared to TDM1, from 6 to 28 months. Overall, the risk of death was reduced by 36%, and the 24-month overall survival rates were 77 and 69%. So really thinking that after a couple of years, the vast majority, 2/3 of patients to 3/4 of patients were alive and doing well. And I think the updated data also suggested there were no new toxicities. So when I think about trastuzumab deruxtecan, heart health is important. And there's also a rare complication relating to pneumonitis and pulmonary fibrosis that needs to be monitored for. So in metastatic HER2-positive breast cancer, we know from previous work that the frontline setting is using a taxane with Herceptin and Perjeta. Based on these data and updated at San Antonio is really using Enhertu or trastuzumab deruxtecan in the second-line setting. And in the third-line setting, this is typically reserved for tucatinib-based therapy or TDM1. So what about HER2 low? Many of you heard about HER2 low after ASCO last year. And really, historically, we've looked at overexpression of HER2, thinking about this as a driver of a more aggressive phenotype of breast cancer. And what we've understood as oncologists and basic science researchers is that some cancers actually have a very low level of HER2 expression, not 0, but have a low level of this. We would call this by immunohistochemistry 1+ or 2+. This is a new classification where about 90% of hormone receptor positive breast cancers have low HER2 expression, and about 10 to 15% of triple negative breast cancer have low HER2 expression. In the Destiny-04 trial that was presented at ASCO in 2022, patients with this HER2 low expression were randomized to Enhertu or trastuzumab deruxtecan or to physician's choice of chemotherapy. Based on this, we saw improvements from 5 months to 10 months in progression-free survival in those with hormone receptor positive disease. And when looking at all patients, a very similar improvement in progression-free survival. And I would just say at San Antonio this year, there was a lot of discussion around what is HER2 low, how low is low, how do we better classify this, knowing that right now it's fairly subjective by the pathologist actually looking at the specimen. Are we using antibody-drug conjugates in the curative intent setting for breast cancer? And I would tell you we're starting to. This was a trial that was presented by Dr. Hurvitz and Dr. Bardia at San Antonio called the TALENT study. And they took patients with curative intent stage 2 or 3 disease that were hormone receptor positive with low HER2 expression and randomized them to trastuzumab deruxtecan versus trastuzumab deruxtecan plus anastrozole. Their goal was to look at a pathologic complete response where their cancer was gone. And this showed activity. Those who had a residual cancer burden of 0 or 1, there were 3 versus 16 in the trastuzumab deruxtecan arm and 2 versus 16 in the anastrozole plus trastuzumab deruxtecan arm. I don't think there's any conclusions out of this at this point, other than to say we are studying it in the curative intent setting and more work needs to be done. So there was not a lot of new data on HER2 low. And I think, as I mentioned to you, there's further work on antibody drug conjugates in the curative intent setting are ongoing. There is a lot of discussion about HER2 1+ versus 2+. I think, as I mentioned to you, work continues to go on about how do we better predict responders and how do we better predict those who will actually develop toxicities, as mentioned. I think I mentioned to you individuals on trastuzumab deruxtecan can develop pulmonary fibrosis. This is obviously a serious but rare complication. And really, we all want to know, how do we predict who is going to develop that? What about other antibody drug conjugates, such as sacituzumab govitecan? This is another antibody drug conjugate that is a humanized anti-TROP2 antibody that has a linker to a topoisomerase 1 inhibitor. This was approved based on the ASCENT trial in metastatic triple-negative breast cancer, which was previously published showing an overall survival improvement from 6.5 to 12 months with using this antibody-drug conjugate. At San Antonio, coming back to that question, how do we actually predict who responds to these drugs? Is there a biomarker such as TROP2 expression that can help us actually guide treatment or pick who should be the ones that are going to respond best to these drugs that have toxicity? And they looked at TROP2 expression less than 100 and over 100. This was presented by Dr. Hope Rugo. And really, they showed that there was actually improvement with sacituzumab govitecan compared to standard chemotherapy in both of the TROP2 expressors, those over 100 and less than 100. So in my mind, I think of this as this drug combination is working for triple-negative breast cancer, but we still have more work to do about the best biomarker to predict those who are responding. So how do we put this together? For triple-negative breast cancer, I think about chemotherapy with or without immunotherapy based on PD-L1 expression, the use of PARP inhibitors for those with BRCA mutations, sacituzumab govitecan as a second-line treatment. And then there is a subset, as I mentioned, about 15% of triple negatives who actually have low HER2 expression, where trastuzumab deruxtecan is a treatment option. What about in hormone receptor positive breast cancer? I mentioned to you the different types of endocrine therapies as well as PARP inhibitors. There is a large subset who have low HER2 expression, where trastuzumab deruxtecan can be an option. Sacituzumab govitecan is now approved, and then there are many other combination chemotherapies. So what happened at San Antonio thinking about the adjuvant or curative intent setting? I think one of the questions we all ask as medical oncologists is who benefits from extended endocrine therapy? We know the standard treatment is 5 years of endocrine therapy, and for many people, 10 years of anti-estrogen treatment. The benefits of 10 years of endocrine therapy is modest, and really the effect may be dependent on treatment sequel and patient subgroups. We also know, however, that these have increased adverse or side effects. Some patients may be more likely to derive benefit than others. And the question oftentimes arises when we're sitting in front of patients to ask, can genomic classifiers predict the risk of who may benefit from extended endocrine therapy? Meaning, is there a way to use somebody's pathologic specimen, thinking about the biology of the cancer and really trying to understand who's going to respond to this prolonged treatment? There was a study that they looked at using MammaPrint in the IDEAL trial to actually try to predict who may benefit from prolonged endocrine therapy. For those of you that are not familiar with MammaPrint, this is a similar gene-based test to Oncotype. In this case, it's a 70-gene genomic test that looks at low risk or high risk hormone positive breast cancers. Those who have what we call high risk really suggests to me that there's a lot of aggressive biology within the cancer itself, and these patients need chemotherapy. They're more at risk for early recurrence. In the low risk, doesn't mean they're not going to get metastatic disease, but really suggests they don't benefit from chemotherapy. So their question was, can we use MammaPrint, this 70 gene assay, to actually predict who may benefit from extended endocrine therapy? Just for background, the IDEAL trial took patients who had taken 5 years of endocrine therapy, didn't matter whether it was a combination of tamoxifen or aromatase inhibitors, and they were randomized to an additional 2 versus 5 years of letrozole. These results were reported out a couple of years ago, suggesting actually there was not a difference in this overall trial of an additional 2.5 versus 5 years of letrozole. And as I mentioned to you, the goal of this update at San Antonio was really asking whether MammaPrint can actually predict who would benefit from an extended endocrine therapy. And what you can see is that those who had a MammaPrint low tumor derived the most benefit from extended endocrine therapy. And this showed a difference from 81% of recurrence-free interval to an improvement to 93% in those who stayed on letrozole for 5 years. As a result, I would conclude that MammaPrint high-risk breast cancers do not derive benefit from extended endocrine therapy. So if you have a genomically high-risk cancer, the question comes up, can we avoid overtreatment and actually stop your treatment after 5 years? If you're a MammaPrint low-risk tumor, these patients actually derive benefit from staying on anti-estrogen treatment from 5 to 10 years based on the IDEAL trial. And as mentioned, this helps us risk stratify who actually may need to stay on these therapies as opposed to thinking about including everybody. So what else came about symptom management and overall outcomes? From the I-SPY2 clinical trial, there were several presentations about immune-related adverse events and how these relate to quality of life in those receiving chemoimmunotherapy in the upfront neoadjuvant setting. I am not going to present a lot of those details, but really say that for individuals getting immunotherapy with chemotherapy, monitoring for things like hypothyroidism as well as adrenal insufficiency are really important. Those safety measures are getting included in clinical trials. And signs and symptoms of adrenal insufficiency are pretty non-specific for a cancer patient, meaning they're usually things like nausea, diarrhea, fatigue. These are things many patients have on chemotherapy anyway. And so really it's important as oncologists, we're checking for labs to detect this to avoid the patients having further complications. I wanted to present an abstract though, looking at cognitive function in survivors. Many of you may be familiar with the RxPonder trial. This was a clinical trial that was used in hormone receptor positive breast cancer. This was a group of patients who had curative intent treatment, and they were randomized to chemotherapy with endocrine treatment or endocrine treatment alone. Within this trial of 5,000 patients, they looked at a sub-study of 568 patients with patient-reported outcomes, where they looked at baseline, 6 months, 12 months, and 36 months after randomization. They asked a series of promised cognitive function concerns. Excuse me. You can see the questions that are part of the promise cognitive function here, which is really about in the past 7 days, have you had trouble concentrating, slow thinking, feels like my brain's not working as well as it usually is, or issues with memory, concentration. And they asked these questions within this sub-study. I think what was notable at San Antonio was the fact that when looking at individuals that were premenopausal, in the maroon arm are individuals who noted sort of worsening symptoms compared to baseline. And you'll see at 6 months and at 12 months, but what was most striking is that at 36 months, those who received chemotherapy in conjunction with endocrine therapy continued to have a worsening complaints around cognitive function compared to those who received anti-estrogen therapy alone. This was different than postmenopausal women, where there was no difference between pre or postmenopausal patients, but it's still worth noting that about 1/3 to 40% of patients actually had worsening symptoms 3 years after their treatment. And to me, this really suggests that chemoendocrine therapy has a greater negative effect on chemotherapy-related cognitive function compared to endocrine therapy alone in both pre and postmenopausal women. Historically, based on the Taylor RX study, this is actually a different conclusion where we did not see this in our younger patient population. And I would also argue that these cognitive function changes really seem to persist over time. To me, this highlights the importance of supportive care, really addressing many physical complaints, but also other symptoms such as sleep, anxiety, depression, that all may impact cognitive function and overall quality of life. And finally, I wanted to talk about the positive trial. So I can't tell you the number of patients that I encounter in the clinic who oftentimes are young. They need chemotherapy. They're really worried about fertility and ask the question about pregnancy outcomes and whether it's safe for them to get pregnant after they've had a diagnosis of breast cancer. So this trial, called the Positive Study, actually really tried to answer this question. This is an international study that's looked at pregnancy outcome and safety, the safety of interrupting endocrine treatment for those with breast cancer. As many of you on the call know, there are many young breast cancer survivors who desire pregnancy. And retrospective studies show that pregnancy after breast cancer does not worsen disease outcomes regardless of hormone receptor status. As we just mentioned, the standard of care is 5 to 10 years of adjuvant endocrine treatment, and this really can limit the conception options for women with hormone receptor positive disease. Pregnancy after breast cancer and interrupting endocrine therapy to attempt pregnancy has not been studied prospectively, and that's what this team of investigators really tried to answer. So they took patients and really recommended that they stay on endocrine therapy for 18 to 30 months. They would stop their endocrine therapy, kind of wash out for 3 months, being not on any treatment, and then try to conceive. They were allowed up to a 2-year break for conception, delivery with or without breastfeeding, with a plan then to resume endocrine therapy to complete their 5 to 10 years of treatment. This is a little bit of a busy slide, but in the figure on the left of your screen, this looks at cumulative incidence of breast cancer-free interval event, really suggesting that after 3 to 4 years, approximately 8% of individuals had an event. They compared this historically to data from the soft and text study that looked at an age-matched group. And you can see from the 2 different lines, there was really no difference in this patient population that had pregnancy compared to those historically that did not. They asked a second question of, if you got pregnant, were your outcomes worse compared to those in the study who did not get pregnant? And there was really no difference. The red lines here actually are those who had no pregnancy compared to the blue lines here. So there was no additional risk of breast cancer recurrence compared to with prior trials, such as the soft and text study. There was no additional risk of breast cancer recurrence in comparing those who became pregnant and those who did not. About 74% of the individuals had at least 1 pregnancy, for a total of 507 pregnancies. The complications from pregnancies were comparable to the general population. This was predominantly hypertension and preeclampsia at 3% and diabetes at 2%. The risk of birth defects was low, and at 48 months, 76% of them had resumed endocrine therapy. So how do we put this all together? I would tell you the positive trial really argues to me that we need to be counseling young patients about fertility preservation. Secondly, I would tell them, pregnancy is an option for you. I think it is safe to interrupt endocrine therapy to consider conceiving. These were younger patients in the trial when you look at most of them. And I always tell my patients that my most favorite days in the clinic are when I get to see new babies come in. That's my most fun day, whether it's on a picture or they actually physically come in. So how do I put San Antonio Breast Cancer Symposium 2022 together? Additional work really continues trying to elucidate the mechanisms of resistance. And for the sake of time, I did not go into all of the biology work that was presented at the meeting. I mentioned briefly that with ESR1. Additional work continues in understanding the role of biomarkers in both predicting response to treatment, but also trying to understand when resistance or recurrence are developing. And recognizing that I did not focus on highlights around radiation or surgical management for the sake of time today. I would love to hear about any questions, and thank you for spending this time with me today.
Okay.
Hope you're on mute, Victoria.
I'm not on mute anymore, am I?
Now I can hear you.
Wonderful. So as I was saying when nobody could hear me, thank you so much. It was such a wonderful presentation. And I have to tell you, your explanation of the difference between SERMs, SERDs, and AIs was the best I've ever heard, honestly. And even though I thought I understood it, I think everybody understood it better with me today. So thank you so very much. And of course, we have many, many, many questions. And let's begin with the question that, I also run a couple of support groups here, Chair. And of course, the CDK4/6 inhibitors for the metastatic ER-positive, HER2-negative patients are the most popular questions. And you alluded to two trials from San Antonio, the Maintain, which actually was reported out at ASCO, and the PACE trial that Dr. May reported out at San Antonio, and of course the Paloma-2 trial from ASCO. So a lot of conversations about palbociclib. So my question to you is, so the results of the Maintain and the PACE trial, do they actually tell us that it's good to continue with ribociclib because palbo is not as good a CDK as the other two? Or is it actually, or does it actually mean that it's a good idea to continue with a different CDK4/6 inhibitor? And based on the Paloma-2 results from ASCO, where the overall survival was not improved in palbociclib, what do you recommend the patients who are on palbo right now to do? And would you change them to ribo, even though they're doing okay on palbo?
Yeah, super good question. So I would tell you a couple of things. I think, first of all, for those, based on some of the other overall survival data, I think if patients walked in the door today with a new diagnosis of metastatic hormone-positive breast cancer, most of us would use ribociclib upfront with endocrine therapy, based on the fact that it's really the only one that has shown an overall survival advantage. That being said, first of all, insurance is not always covering that and are really suggesting palbo or the Verzenio. In answering your question, what if you're on palbo right now and you're looking at all of this data saying, do I need to switch my treatment? If you are doing really well on your therapy right now, I would not switch your treatment. I can tell you, I'm not switching my patients right now. What I would tell you from San Antonio, though, is that if you start having some progression, then is a good time to switch to ribo. So switch to Kisqali, ribociclib at the time you're seeing some slight progression. But I don't think you need to otherwise.
Thank you. Thank you. That's a good question, because as I said, this is one of the most popular questions we get. Okay, so another one. So you mentioned the two new oral SERDs, and I can tell you, and you know that from your practice, that people are so excited about oral SERDs. But I keep telling them that elacestrant and the other one as well will only be approved as monotreatments for now. Do you suspect that, and I'm sure there will be other trials, or they're running already on the combination trials. Do you think at some point soon the doctors will start switching their patients from, as soon as this gets approved, from Faslodex to an oral SERD, even in combination with the other drugs?
So as you're asking that question, I'm thinking of my patients who came into clinic yesterday telling me that their rear ends were sore.
That's right. They're ready. They are so ready. Yeah, I'm telling you, this is like the number one discussion, the number one discussion.
So I say that in a joking manner, but I mean that sincerely, right? I think honestly, that will be part of the discussion with patients. For some who hate to take pills, fulvestrant may be a good choice. But I do think the oral SERDs, people are really excited about them, and especially for that group that has that
ESR1
mutation, for
Yes.
sure. Yep, for sure.
Wonderful. Yeah, we can't wait.
Yeah.
For this to be approved.
I agree. There's a lot of hype and excitement about it, and for good reason.
And it's funny, the LSS trend, I think, got more attention than the other drug, and the results from the other trial, Serena, look better.
They do. I agree with you. The results from Serena look a lot better than the Emerald trial, but.
All right, so let's switch to the questions that people actually are asking. So there is a question about AIs. Do you feel that all AIs are equal? And would you prefer one AI to another? And is there a difference in how you would prescribe an AI depending on age and other adverse effects?
Yeah, that's a good question. So there, as far as like efficacy data, I would tell you anastrozole and letrozole honestly look equivalent. The exemestane is a slightly different compound in that it's what we call a steroidal aromatase inhibitor. Rarely people can have higher sugars on exemestane. It's rare, but for those reasons, it's not usually my first choice. And then how do you pick between anastrozole and letrozole, knowing that they look equivalent in all the data I've seen? You and I were talking before we started the meeting that the other hat I wear is a lot of cardio-oncology. And based on that, the rates of cardiac events and like high blood pressure, high cholesterol are higher with anastrozole. So my preference is to use letrozole first. I think it's okay to use the other one, but that's how I pick it based on the side effect profile.
Wonderful, thank you. Okay, so let's talk about my favorite topic, the ADCs. And thank you for explaining to us what they were. There are still a lot of questions about them. And so let's talk about the HER2 low and HER2 positive. So for people, just let's explain to the listeners that what is the difference between HER2 low and HER2 positive? And are HER2 low people still considered HER2 negative for all intents and purposes?
Super good question. So breast cancer cell, I'm going to do my best to try to explain this simply. So, breast cancer cells all have some overexpression of HER2, which is really an epidermal growth factor receptor. It's linked to a tyrosine kinase. When we say somebody has HER2 positive breast cancer, almost think of it as that cell, which is about 20 to 25% of breast cancers. That cell has an abundance of receptors on the surface, which really means they can be a more aggressive biology by sort of this rapid turnover and stimulation of the cell. So HER2 low would tell you that they're in between that. They're not negative and they're not the abundant. They sort of have this intermediary. And that's where I was mentioning that there's really, it's subjective to pathology of what we call 1+ versus 2+. You can imagine there was a lot of conversation at the meeting about how do we better use technology to actually make this like a computational or a specific number to have a better outline, as opposed to like, what does the pathologist eye say? Is this 1+ or 2+? So that's how I would think about the distinction. So HER2 low is sort of this intermediary. HER2 low today is still considered HER2 negative. So if somebody presents with curative intent setting, we're not using HER2 low as a distinction. And so those patients would really be considered HER2 negative when they're treated in the curative intent setting.
Thank you. Okay, so here's a question that I've asked before, and I want to ask you. Two trials, Destiny-Breast03 and Destiny-Breast04, the same antibody-drug conjugate. Different results. Destiny-Breast04, of course, garnered a standing ovation at ASCO for HER2 low. So why are the results so different? When you just presented the Destiny-Breast03 results for HER2 positive population, they are incredible, right? They blow your mind how wonderful they are. Why is there such a difference between the results for Destiny-Breast03 and Destiny-Breast04?
Yeah, it's just a good question. The patient populations were slightly different. Would be sort of the first answer. In Destiny-03, you're looking at HER2 positive, and those patients all had chemotherapy and some conjugated antibody treatments. In the Destiny-04, you're looking at HER2 low expression. Most of them had some chemotherapy, but some had just endocrine treatment and then enrolled on it. And so I would say they're slightly different in terms of the patient populations. And I think that's why we're seeing the outcomes as slightly different. Both still really in favor of trastuzumab deruxtecan. And I think that the other thing I would say is the toxicity profiles in both the trials were really similar.
Right. But we all know by now that in HER2 is not a walk in the park.
Right.
It's a top drug. It has. I mean, I know people who do very, very well on it, but we also know people who have serious side effects with it. So would you still recommend your patients to go on an HER2 if they are HER2 low after they progress on CDK4/6 inhibitors, or would you use a one line of chemo, say capecitabine, before you go to an HER2?
Yeah, that's an interesting question. How do you put that order together? I think, for one, I would say if you're on a CDK4/6 inhibitor and you're HER2 low and you're having some progression, I think what we saw as we were chatting earlier, you can use a different CDK4/6 inhibitor like ribociclib if you're having sort of what I'm going to describe as slight progression. And I would tell you in clinical practice, I have many patients like that where I've switched them and they're doing really well. How do you decide when to use trastuzumab deruxtecan? When do you use like an oral chemotherapy like capecitabine? Honestly, I usually have a conversation with patients about it. For some, the toxicity profiles are going to be a little different. So you're going to look at heart and lung function, for example, that might have a higher risk with the trastuzumab deruxtecan. I think that some patients prefer oral medications, in which case capecitabine is a nice different medications. And I think as we're using more in HER2, I would also tell you I'm seeing more and more hair loss with it, which was honestly not so appreciated on the clinical trials. So if hair loss is really important to a patient, capecitabine is not going to do that. And so that might be a good alternative option.
But they do use the cold caps within HER2, don't they?
You can, but the more patients I talk to around the country, I would tell you that's very site specific who uses it. I can tell you within our own clinical practice, it's not used at every single one of the chemotherapy centers around the country. And there is a discrepancy on the pay for it. And so I find some patient populations can't afford cold capping. And so even though there's programs to try to support them, that may still impact the patient's decision.
Thank you. Okay, I'm going to go to the questions that have been given to us in the chat. And so I'm going to just read them to you without this is a really good question because we have these discussions all the time in my support group. Is it safe to occasionally skip the CDK4/6 dose once a week or so? That's a good one, right?
Yeah, I'm laughing because I think that's like the $1 million question, right?
I know, right?
Is it going to affect my outcomes? You know what? Usually, what I try to tell patients is, I want you to take it the way it's prescribed. That's how it was studied in the clinical trial. If you miss a dose, that's probably fine. You know, you catch back up on it. If you're intentionally missing a dose, meaning every Sunday you're going to say,
You decide to take
then you're on your own. I don't know how to.
Well, how do you feel about, it's an aside question, how do you feel about taking a vacation from your treatment once in a while? Taking, you know, if you're doing well on a drug for a considerable amount of time, would you recommend?
So I'm going to answer your question in two ways, actually. So first of all, and this came out well loud and clear in the metastatic session, and this is my firm believer as an oncologist. When you have a diagnosis of metastatic breast cancer, quality of life and living well is really important.
Exactly.
So taking those trips, doing those activities that are going to keep you feeling well and allowing you to see your family and other things that are important to you is essential. So how do I incorporate that in my practice? If people are on oral medications and they're tolerating them well, they're going to sort of keep taking them.
Right.
If they're on IV infusions, we will sometimes work infusions around their trips and other things. Can you take like a 3-month holiday? I think that's sometimes a bigger question. A week or two, I don't really mind.
Yeah.
The 3-month kind of question, you want to do it with your oncologist. So you're having really a joint conversation about what that might look like for your disease. Because sometimes cancer will progress during that time. And so I think you have to sit down with your doctor and really think about the pros and cons of that.
Thank you very much. Yes. So you're on your own if you take Sunday off from your.
Yeah, you're on your own then.
That's right. Okay, so here's a question, and I think I'm going to rephrase it, but because I think I understand what a person who is asking the question means. So for HER2 positive early stage patients, if they did not have complete pathological response with their neoadjuvant chemo, they usually go on neratinib for a year, right, after their surgery. And I think some go on T-DM1 as well, right? It's either neratinib or T-DM1 these days. Do we see any improvement from people who had done a year of adjuvant neratinib or T-DM1 in how their risk of progressing to MBC is?
Good question. So just to kind of paraphrase it, for patients with HER2 positive disease and they're getting curative intent treatment, it doesn't all disappear with their treatment. Now they come to see me after surgery. You know, I think based on the Catherine study, I would recommend a year of Kadcyla or T-DM1.
Instead of neratinib these days?
Yeah, I would. Yeah. And I'll come back and answer the question about neratinib. But would use Kadcyla in that setting for a year. It's been shown to be superior in improving outcomes compared to Herceptin alone. Where are we using neratinib? I think the most efficacious data is in triple positive breast cancer. To consider neratinib after that, if you had somebody with a triple positive breast cancer, it's a tough drug. So I would say you want to maximize your anti-estrogen treatment. So if I have a young woman, I'm going to probably suppress their ovaries and put them on an aromatase inhibitor and be talking to them about it.
Thank you. So I'm going to ask a question that I wouldn't ask myself, but it's written right here. So I'm
Yeah.
asking it. And I feel a little embarrassed because people with HER2 positive metastatic breast cancer have the abundance of riches. But the question here is, are there any new HER2 positive, are there new interesting drugs in the pipeline for the HER2 positive MBC patients?
Yeah, there are several different clinical trials. Most of them are using oral tyrosine kinase inhibitors. They are in clinical trial right now, is what I would tell you. So stay tuned.
Thank you. Okay, another one. If you progress on a low dose of palbo or any other CDK4/6 inhibitor, would you increase the dosage by the next thing you do? Well, I guess if you progress and you move on to another CDK4/6, would you increase the dose?
So I would not increase it. I mean, I would start with the standard treatment. I think for patients who have had a dose reduction on their current treatment, usually they had a dose reduction for a reason. Either their blood counts weren't tolerating it, or they had, say, bad diarrhea, like with the abemaciclib. So I would just use the standard dosing where I would start. Victoria, it's funny, there's a chat I can see too that I was going to answer 2 questions on it.
Oh, please do.
Yeah.
Please do.
So I think someone wrote in, do we know if the antibody-drug conjugates are safe in metastatic disease involving the peritoneum?
Yes, thank you. I was thinking that may be too specific, but please go ahead.
Yeah, maybe it's specific, but I would just tell you, yes, patients who have metastatic disease, who have, whether it's disease in the liver or the lungs or the peritoneum, those drugs are safe to use. And I wanted to just clarify one thing from my presentation from another question that came in, was just about if you're on Ibrance and letrozole, can you stop letrozole? So kind of coming back to your question about the CDK4/6 inhibitors, the only CDK4/6 inhibitor that has efficacy by itself, meaning not with anti-estrogen treatment, is abemaciclib. So if you're on palbo or Ibrance,
right,
you got to keep taking the letrozole. Sorry.
Okay, well, so I wanted to ask you the last question because I think we have time for one more question. That's your specialty, cardiotoxicity. People with HER2 positive cancers sometimes develop, well, actually 2 questions then. The HER2 positive cancers with cardiotoxicity. What would you do in the case when a person is having some symptoms? Would you just stop Herceptin for a while and then go back, or switch to a different treatment altogether?
Really good question. So it depends on the setting, if it's curative intent or not. And it also depends on how much of a change in the cardiac function there is. So technically, I'm going to answer this in 2 ways. Technically, if there's a decline in ejection fraction and on Herceptin, the current package insert or safety guidelines would tell you hold it for a couple of weeks and then recheck your cardiac function. And if it's improved, to go ahead and restart the medication. There are 2 trials for patients. We know anti-HER2 drugs, especially for patients living with metastatic disease, is really, really important, and is helping patients live for many years, if not decades. In that situation, if the decline in their heart function is mild, down into what we call the ejection fraction of like 40%, there are studies that in close follow-up with cardiologists, you can keep those patients on their Herceptin. So I work really closely with cardio-oncologists. We typically will put patients on ACE inhibitors or beta blockers and keep them on their treatment.
Okay, good, thank you. Okay, so the last question, I promise, this is the last one, and it's about ILD within HER2. So how it is a very serious issue, and I have talked to oncologists. It is a problem. Not common, very rare, but still a problem.
Yeah.
Well, how do you make sure that it's monitored? Do you, I mean, of course, patients can report, and reporting is important, but what are the diagnostic tools you use to monitor for ILD?
So I think the people who are at highest risk for that are individuals who have underlying lung disease or have a long tobacco use history or say COPD. For any of those patients who need the drugs, I would recommend getting pulmonary function tests to really look at baseline lung functions, and that those can be assessed during the course of their treatment as well. And obviously for anyone that's listening who does have some shortness of breath or cough, you know, and that seems like it's something new while they're on the drug, they should definitely be reporting those symptoms.
You know what I have to say? I'm so sorry. It's already past 3 o'clock. I can pretend that it's not, but it is. And it was such an incredible pleasure to have you, and you are wonderful. Thank you so much. Unfortunately, we only were able to go through a very small portion of the questions, but you did promise you'll come on the podcast.
Yeah.
So I will ask all of these questions on the podcast. So
thank you for having me.
Thank you so very, very much. And so what am I supposed to say now? Thank you, Dr. Blaes, again for informative program, and thanks to all of you for participating and submitting questions. Make sure to check out our upcoming educational programs and support groups, and follow us on social media as well. Please take a moment to fill out the survey at the end of the webinar, and the survey will show up in the browser when the webinar ends. And the link will also be in the follow-up email. All surveys, I have to tell you, are anonymous. So this concludes our webinar. And again, I want to thank you so much.
Yeah, thank you very much. I appreciate it. It was a fun conversation and very good questions.
Thank you. And I'll talk to you soon, I promise. Bye-bye. Thank you.
Bye-bye.